uni is done. So his topic is partial knee replacement, his experience in the Indian scenario.
Here's the pointer.
Mic on it. Yeah. Hello. Yeah. So first of all, I would like to thank Dr. Ashish and his team for putting up such a great show. It's wonderful to be here. And after this very informative talk by Dr. Gulati about the benefits of partial replacement, I'm going to just discuss a little bit about what our experience has been now. This partial replacement is gradually getting accepted amongst orthopedic fraternity. We have been doing partial replacement for more than 7-8 years now, and our numbers are gradually increasing. So I just thought that it might be a good platform to share the results of partial. So I would, some of the talks would be repeating, so I will be skipping quite a few slides and move on to the results, because we have already seen what are the indications of the surgery, what are the surgical steps. So I'll be moving on. So this is a classical type of an X-ray where a patient might still be a good candidate for a partial, in spite the fact that some of colleagues would rightly say that this is a good case for a TKR also, but those who are doing partials on a regular basis might get away doing a partial on such a situation. So I'll probably just move on and saying that, okay, we have seen the indications, it's an anteromedial arthritis. This is not a new system, the mobile bearing knees. This is since 1976. Few design modifications has been made, but the overall design has remained pretty constant. Moving on, why partial? I think as seen, it's a smaller surgery, smaller cut, less painful, easier recovery, easier mobilization. And as we were seeing in the robotic talk today, we are not subluxating the knee, it's less painful. We are not cutting the ligaments, it is less painful. We are not doing any releases. So this is why it is less painful. There are multiple reasons for it being less painful. And as a result of the fact that all the ligaments are preserved, people also have a much better and much natural gait compared to somebody who has a TKR. Patients with TKR also have great results pain-wise, but functionally their gait is slightly different than a natural gait. And therefore, it leads to better functional scores as well. So this is an X-ray this is a clinical picture comparing TKR incision on one side and a partial replacement incision on the other. And we can see the difference in the size of the surgery. Apart from the fact that it is functionally better, medically also, partial replacement has much less complication risks. Dreaded complications like infection, MI, CVA, especially in people who have medical comorbidities, diabetes and post-CABGs and history of strokes and other issues which we routinely encounter in our elderly age group patients, especially the elderly infirm patients. Partial replacement, if they are good candidates for it, will be a much safer surgery to do than a total replacement. And in my opinion, elderly patients are probably a better candidate for a partial than younger patients. Younger patients have their own advantages, but even in elderly, we should not discount कि इनको partial करने का ज़रूरत नहीं, is old, we can do a total on him. But no, if there is an elderly patient who has medical issues, partial is probably a safer option. So survival-wise, from the Oxford group, it's a very, very high survival rate, 98% at 10 years. In the independent studies also, the similar results have been shown, more than 94-95% survival rate at 10 years. So these are the data which show the overall survival rate of above 90% from the Oxford as well as from various other centers all over the world who have been doing this procedure on a regular basis. But as Dr. Gulati mentioned, one needs to be doing this regularly. If this surgery is done once in a while, then the failure rate is very high. You have to be doing it regularly to get good at it, and then only the results will come. And to get good at it, it's not only attending the conference. I would strongly recommend younger colleagues who want to get into this surgery is that they must attend Oxford knee course, which happens once a year or maybe once in 2 years. And that's a course to attend to learn more about the surgical technique and indication and other aspects of it. So we have been doing this procedure since quite a few years now. This is a little old data. I think we have done more than 250 knees. by now, but let me just read the data figures that I have. So 224 knees in 163 patients on an average age of 62 with a range from 41 to 86 years. Bilateral knees were done in 61 patients and unilateral in 102. As we normally find, females are more common age groups, more common gender who have arthritis in our population. So female constituted majority of our patients. And 181 knees out of 124 were done in females. Males were only 43 knees. BMI roughly around 30. From 18 to 41. So I fully agree, obesity is not a contraindication. I frequently do it in obese patients as well. No revision so far. One dislocation, well, not by me. No revision so far. One dislocation which got sort of, I had to change the poly to a slightly one size bigger poly. Patient was trying to sit cross-legged and do some yoga asanas. One superficial infection which settled with a washout, and a pulmonary embolism which thankfully was non-fatal. So this is the data in our sort of current series over the last few years. And as I was mentioning, lesser the number of patients, more is the complication, more are the number of patients per center, lesser is the complication. So this is one important thing to realize. Don't do it once in a while. If you subscribe to the ethos of Oxford, then do it regularly. So this is how an anteromedial OA would look like on arthroscopy. Small area, bone on bone, anteriorly around the medial meniscus, in the posterior compartment, the posterior part of the joint should look absolutely normal. This slide was already shown in the last talk. So this is a classical X-ray on AP. On the lateral, we see anterior depression, posterior intact. There should not be depression posteriorly. The valgus stress views that we routinely do, or initially one must do. Later on, as you get more experience, you can just do clinical examination, make sure that the varus is correctable. And if, as a clinician, you find that the varus deformity is correctable, then you might want to give up the doing the lateral, the stress views. Another extended indication which was not mentioned in the last talk was medial femoral condyle spontaneous osteonecrosis. So SONC, what we used to call as SONC. There are quite a few patients that we see of SONC which are which get good relief after medial uni. And certain patients where we do both procedures together, ACL as well as medial uni. Contraindication, any inflammatory arthritis, infection, absent ACL. Previous HTOs were contraindication. Recently, some papers have come up in which they have even tried it in previous HTOs. I am keeping my eyes on it. I haven't tried any on it myself yet. So going forward, these are the X-rays post-operatively. We can see the incision. We can see how the patient can bend the knee. I don't know how will the, yeah. So this is how she's walking 15, 20 days post-surgery. Pretty comfortable walk. Elderly patient, 60, 68, 67-year-old. Sorry, I'm just going to. So this is a case of a SONC. We can see a small ulcer in the medial tibial, medial femoral condyle with MRI showing changes of SONC clearly. This is the X-ray. So I always do an X-ray as recommended by Oxford group in the OT on a C-arm just to make sure that I've done it properly. And all of the patient, 250 patients I have these X-rays. Every patient gets these X-rays. They don't leave my OT unless I've done these X-rays. So that's a true picture that we see. That's what we, because when they go for a routine X-ray, in the radiographer will position them whatever they want to position them, and we really don't know the position of the implant. So this is the X-rays that we do always in our patients. So this is an patient with a PCL avulsion, grade 2 laxity, but not a grade 3. And this patient also did pretty well clinically post-surgery. So this patient, as you can see, still has the stitches on 12 days post-operation, and you can see the bend is more than 100 degrees already. So rarely more than 4 or 5 sessions of physiotherapy are required, and the recovery is much easier. Again, another patient coming for stitch removal. The clips are still on, and this is how she's walking without any support, without any stick, without any walker. 12 days, 15 days post-surgery. Another patient, 2 months post-op, bilateral Oxford, and the gait becomes nearly like a normal patient. You cannot tell if patient has had a surgery or not. So they tend to recover much better. They appreciate the functional aspects of it much more than a TKR. So this was the X-rays which I showed you initially. This is an 80-year-old patient, my first patient that I did an Oxford on. 80-year-old, he had some medical issues, father of a doctor, and we did a bilateral Oxford on him. And he passed away 2 years ago, I think, after 7 years of having a very useful life with the Oxfords. So as I said, Oxford partial knee course is the course to go to if you want to learn more about this procedure. Thank you very much, and I'll be open to any questions.
Thank you. Thank you, Dr. Jayant. Any questions from the audience side?
Yeah, Dr. Jayant, wonderful presentation. I had one question. So a lot of our Indian patients are osteoporotic, and a lot of the tibial plateaus that you see are almost like a champagne glass, a lot of them. So in these kind of cases, do you do anything different? Do you get a bone mineral density before surgery or anything of that sort to make sure that there's no subsidence later on?
Yeah. So I think that's an excellent question. I think the most important part that you picked up was the champagne glass shape of the tibia. Look, I think somebody having a generalized osteoporosis is relevant, but it is not very relevant. Reason being that the subchondral bone in osteoarthritis, as the pathology goes, is always sclerotic. We do not encounter osteoporosis in the subchondral sclerotic bone. So we should, if you're not cutting the tibia very deep, if you're just skimming on the surface, we are really in a hard bone. We are not in a soft bone. So if we cut tibia too deep, then we break the bone. But if you are cutting it properly, a millimeter or 2 millimeter below the damage area, then the bone quality is pretty good, even in osteoporotic patient. So that I haven't encountered any problem due to osteoporosis, and I don't do DEXA scan as a routine thing in all my patients. Now coming to the champagne glass part of the deformity, the important part is that there is a keel in this tibial base plate, and if our posterior cortex breaks while preparing the keel, we should abandon the surgery and move on to a TKR without fail. Because if somebody is doing Oxford with a posterior blowout, we call it a posterior blowout. If there's a posterior blowout and you're doing an Oxford, the tibia will break. So it is very important to make sure that your tibia base plate is not shifted posteriorly when you're preparing the tibia, so as to protect the posterior blowout, especially in our population. So I think that's the important point to remember. But that's a technical nuance. I thought I'll skip it because a lot of people do not do the surgery here, so that's why I just sort of missed on it.
Dr. Jayant, very good lecture. My question is, you have said the extended indications of unicondylar knee. One of these are ACL tear and posterior avulsion of the knee. So when you plan the unicondylar knee replacement and in the OT, before that you don't know whether ACL injury or not, but at the time of surgery you just find out the ACL injury. So what is your plan to do a ACL reconstruction at the same time or do it later?
Yeah. So I think I approach this situation differently in different age groups. In a younger patient, where I am suspecting ACL on clinical examination, I'll probably do an MRI scan and know it upfront straight away. So in a younger individual, less than 55 typically, if I have any concerns about ACL, then I would do an MRI. In an older individual, because if somebody has a chronic ACL tear, they will wear out their posterior part of the tibial plateau. On the X-rays, we'll pick it up, and the deformity will be fixed. But if on an older individual, if I find that the ACL is intact, but it is very flimsy, which can happen once in a while, and if the ACL is not dependable, then I will do a TKR. Every patient where I am going in for an Oxford, I take a consent for a TKR as my plan B. I don't go in with a promise that I Oxford hi kar aunga. If I do a blowout, if I have a bad day, I do some release of deep medial collateral ligament accidentally, I would have to do a TKR. So every patient gets consented for a TKR. So in a younger patient, I will reconstruct the ACL. In an older patient, I'll move on to a TKR. That's the answer.
Okay, thank you so much, sir, Jayant sir, for you sharing your experience in Indian scenario for partial knee replacement. May I now invite Dr. Iswar Bora, sir, for treatment alternative for osteoarthritis knee other than TKR.